Dr. Lawrence Leonard Weed, better known as Larry Weed, created the problem-oriented medical record in the 1960s, a clever format for medical charting widely used in American hospitals today, a method designed to make it more difficult to overlook one or more of a patient's problems. Dr. Larry Weed worried over 50 years ago about the cognitive overload occurring in medical practice. He would ask, "Why are we teaching doctors to practice medicine by memory?" He recognized even then that medical practice needs methods and tools to guide information collection and its analysis. Doctors, he complained, were being trained to act as oracles, the exact word he used, oracles, who magically diagnosed problems and mandated treatments that non-physicians in the healthcare system were then charged to follow precisely to restore good health to patients. Mandating treatment without explanation to the healthcare team, we're calling here the prescriptive mode of medical practice. Physicians typically write orders for others to carry out. An informative mode of medical practice would instead allow the entire care team and the patient to understand fully the objectives and the uncertainty of the care plan. Weed also complained that his residents did not consistently conduct complete investigations of their patients' symptoms, but instead they jumped to a diagnosis before collecting all the relevant information. Was he right? In 2018, Newsweek reported on a study that found the average physician interrupts his or her patient after only 11 seconds as they begin to explain why they came to see the doctor, seeming to validate Dr. Weed's observation that he made half a century before. Weed commonly observed that the patients in the hospital seemed to die on the wrong medical specialty service. By that he meant that while they were under the care of one specialist, the patient would die from a condition usually treated by a different specialist. To fight this trend, Weed advocated for a system of medical treatment roadmaps, a set of guidelines that would allow physicians and other members of the care team to recognize and give proper treatment for issues outside their primary expertise. He was trying to enable the oracle mentality to act more like a guide for patients using this set of treatment maps. These maps were not meant for memorization, but were available for review on a computer screen. We'd found that patients were using these computers more often than the medical staff, a fact that infuriated Weed's colleagues because the patients were asking much more complicated questions than they previously had asked. The power of Weed's ideas about widely sharing treatment knowledge and objectives have proven their worth more recently in the hands of Dr. Peter Pronovost. Dr. Pronovost, while practicing intensive care at Johns Hopkins University, required all the physicians making rounds on patients in his unit to define observable treatment goals to the nursing staff for each patient on each day. This requirement went beyond the tradition of having physicians simply write orders without defining any objectives. This change in practice at Hopkins produced a clear documented improvement in outcomes and saved money for the hospital by shortening patients' length of stay in intensive care. When the entire care team understands the specific objectives of their care instead of simply carrying out orders, very important things change. If a medication or treatment the physician ordered appears to be acting contrary to the care objective, the nurse will call the physician to adjust the treatment instead of simply continuing to carry out the counterproductive order. They found at Johns Hopkins that physical therapists and pharmacists and other categories of healthcare professionals were suddenly empowered by this method to use their skills and experience to creatively move the patient toward the objectives instead of simply carrying out doctor's orders. Dr. Pronovost reported that his physician colleagues did not initially appreciate the extra step required of them to define daily objectives, nor did they like getting more telephone calls asking for revisions in their orders, until they started seeing much better outcomes. If we change the prescriptive mode of medical care into a more informative, objective-driven system, we would expect fewer medical errors or missteps, as Dr. Pronovost demonstrated. The informative mode of practice adds redundancy and fault tolerance to medical care. The design challenge lies in creating tools and systems to make this practice mode easier, more consistent, and truly informative. That's exactly what Larry Weed wanted a half-century ago, and we have not yet made that happen throughout our healthcare system. Creating workflow tools to track the objectives of care for each patient while adding cues for safe practice around these objectives constitutes a worthy, non-trivial challenge for the industrial design community. The solution will require the application of information technology. But truly effective tools will require much more. Designers must create tools that can work accurately and unobtrusively in the chaos of the clinical setting without disrupting the important bonding that goes on between patient and caregiver. Hospitals know about the success of Dr. Pronovost's ICU initiative, and some have experimented with their own versions of less prescriptive clinical workflows. But we have not seen projects actively employ the skills of industrial designers. Hospital information systems do not currently facilitate the creation of individual patient care objectives or guide the refinement of specific patient care goals. Designers could bring to this process their trademark mapping methodologies for workflows to enhance the delivery of more goal-directed information directly to the bedside. Again, I want to repeat, we want to do this without disrupting the personal attention caregivers provide to their patients. Information scientists have proposed special computer languages that could more consistently carry out treatment protocols in hospitals, managing not only medication administration, but also automated adjustments of treatments based on clinical or laboratory findings. So far, this work appears to represent an extension of the traditional prescriptive mode of medical practice, although designers could mold such advances into a more informative mode of delivery. Warping prescriptive medicine into informative medicine represents a foundation strategy widely applicable in our quest for patient safety. Designers have skills that make complex problems into visual presentations that make better approaches more easily evident. We have not properly tasked that capability to make the complexity of medical knowledge and treatments more manageable for all concerned. Larry Weed argued that many traditions of medical education and practice restrain progress toward a more informative mode of medical care delivery. But we now have clear evidence we must tear down such barriers. We will build on this notion of an informative mode of practice in Section 3 of our crash course in patient safety.